Okay, next talk is about recurrence rate of keloids after excision and cryotherapy. It's not on behalf of me, but on behalf of my student, Chikbo. So wish him luck with this presentation.
Thank you. Yes. I'll introduce myself. My name is Shibo Udemba. My name is Shibo Udemba. I'm currently a sixth-year medical student at the University of Amsterdam. And together with Dr. Niesen, we conducted a retrospective cohort study to evaluate the effects to evaluate keloid recurrence after debulking combined with cryotherapy. First of all, I want to tell you something about the background. Cryotherapy is a well-established treatment for keloids, but this type of treatment often requires multiple sessions before complete clearance is achieved. The daily practice, Frank mostly, became a bit impatient and was wondering if results could be achieved more quickly. And that is how this idea came to mind. And that's how this idea came to mind and led to the simple question, why not first debulk the keloid and afterwards use cryotherapy to treat the remaining tissue? Okay, the study design. The study was a retrospective single-arm cohort study conducted at the SCAR clinic here at the Amsterdam University Medical Center. All patients in this study were treated with surgical excision followed by cryotherapy, as stated earlier, and the patients underwent this treatment between 2021 and 2024. A minimum follow-up period of 1 year was handed. Using two predefined booking codes for keloid treatment, the Epic Data Management Center generated a list of potential patients. In total, 684 potential participants were identified. Following a medical record review, patients were excluded for several reasons, as seen here in the flowchart. Some of the exclusion criteria were no treatment consisting of the intervention of interest, duplicates, of course, other pathologies than a keloid that were treated, and a follow-up period less than 1 year. After applying these exclusion criteria to our list, a total of 22 patients remained, and the final analysis was done on these patients. So here we have a short video of Frank, of Dr. Niesen, performing the intervention. And afterwards, the cryotherapy was administered for approximately 10 seconds. Yeah. 2 weeks after this procedure that has been done, the patients would present themselves once more at the clinic, and an additional 20 seconds of cryotherapy would be administered. Yep. Yeah. Okay, the outcome measurements. The keloid recurrence was assessed using the record classification that was presented by Mr. Tergen at the 5th International Keloid Symposium last year in Shanghai. No statistical analysis was performed because of the absence of a control group. As stated earlier, this study was a single-arm study, so no control group we didn't have any control group. We searched for a suitable control group in the literature, but we couldn't find a control group that used the intervention of interest and measured the results using the record classification. Now here we have some patient demographics. The average age of the patients were 26 years old. The bulk of the participants were female. 2 participants out of the 22 had relevant comorbidities. Both these patients had cutaneous lupus disease, and none of the patients used relevant medication that could interfere with the wound regeneration process. Now we also have some lesion characteristics as seen in the table. Most of the patients were treated for air loop keloids. And we also have the cause and previous treatments that patients had before the intervention was used. Okay, before I want to share the results with you, I want to give a quick recap of the record classification. The record classification has 5 categories, and this is a simplified version of it. Complete clearance is the first category. It speaks for itself. This is when complete disappearance of the keloid lesion occurs. Then you have near complete remission. This is the near total remission with minimal residual tissue. The partial remission, this is when more than 30% reduction in lesion size occurs. Stable disease, this is when no significant reduction or increase of the lesion size occurs. And then you have the progressive disease. This is when more than 20% of the keloid lesion increases or new keloids form. Now, after applying these results to our study, we can see the following. Out of the 22 participants, 5 of them achieved complete remission. 10 out of the 22 patients achieved near complete remission. The bulk of these patients reported elevation around the lesion edges after the initial intervention was done. Then 1 patient reported a partial remission, so more than 30% reduction in size of the keloid, and 6 out of the 22 patients had a stable disease. These patients had a recurrence after the intervention, that was performed, but the recurrent keloid was not bigger than the original keloid, or more or less the same size as the original keloid. In the second flowchart, you can also see how the location of the keloids were distributed across the different category groups. Okay, now then conclusions. Despite the promising result, the study does have some limitations, including its retrospective design, which makes it more prone to certain types of bias. The limited number of patients, and because it was a single-arm study without a control group and no suitable control group from the literature, no statistical analysis was feasible to test the validity of the results. And therefore, the findings of this study should be interpreted with caution. As in a lot of other keloid studies, larger prospective controlled studies are needed to provide more robust evidence on the effectiveness of surgical debulking followed by cryotherapy. And this was our presentation. I want to thank you for your time.
There's a question.
It's actually a question for you, Frank. Do you remember or know which patients you chose to do this surgery on, or to use this technique to for the?
Which patients I choose? That are the patients that I could close the excision without a lot of tension. And because I'm afraid to do surgery and do something extra, I know just we started slowly by slowly, and you see the recurrence rate is lower because I do a longer period of freezing. In the beginning, I thought, well, maybe 10 seconds. Now, when I do the operation and I stitch it, I do it at least 20 seconds. And when I remove the stitches in 2 weeks, I do it 20 or 30 seconds as well. But I want to close without any tension. Yeah. No, I resected the keloid completely. Of course, when the keloid is too big, you can use the epidermal and a part of the dermal layer to have enough tissue to close it. That's true. And maybe that works as well. I don't know, but that's not inside this study. And because the ear is more favorable than the rest of the body, but there are a lot of patients, they come with keloid tissue after breast reduction. And I started to try to prevent that. And in some cases it works, but not in all. Because we don't do something about the origin of these keloids. We only treat the symptomology. Yeah. A lot of later.
I'm not speaking, so I'm asking all the questions. Sorry, again, for the timing, we didn't see the time point. And the other question I have, you have stable disease. So if you do surgery in the beginning, does it grow back to the size it had before to be classified as stable disease? Or does it mean stable after what was left after the excision? Because you do the debulking. So how do you classify stable disease and debulking?
Yes, I understand the question. Yeah, how I interpreted the record criteria was as following. Of course, when you debulk the keloid initial, there's no, recurrence. And how I assessed it was I looked at the records post-operatively with a follow-up period of 1 year. And if I saw that the keloid size was reported the same as the original keloid, then I put them in the stable disease category. So that's how I interpreted it.
But look at the size of a kind of keloid like this. The stable disease is more when we had to do a secondary cryotherapy session. And there were no keloids growing bigger than the original. They almost all went smaller, remained smaller.
How do you turn it on?
But
Hello? Can I talk? No.
the time point, you mean the follow-up? The follow-up is at least 1 year. Oh no, when it comes back, it can be 3 months, it can be a year. Yeah.
Hello? I want to ask you a question.
Yes.
Firstly, sorry I came a bit late, but that's not a good cosmetic result. You got depigmentation, that's terrible. Interestingly, let me finish.
Yeah, yeah.
Interestingly, it doesn't look good. With radiation, it gets darker because radiation makes pigment. So a black-colored person is pleased. We don't get a white spot. We don't get depigmentation. We get increased pigmentation. That's unacceptable.
Well, the thing is that these pictures are his. And this was the only...
Dr. Turk, unacceptable.
No. Okay. He's very good at making pictures.
Yes.
I'm not that good at making pictures. Sorry.
Surgery, you.
No. This is an example of cryotherapy alone. He took a patient with only cryotherapy. Right. So this is not excision and cryotherapy.
You agree with me, it's not cosmetic.
Okay, it is true that when you do cryotherapy, that the pigmentation can disappear, even when you do resection before.
It's better for white skin.
Well, but the recurrence rate of radiation, in my opinion, is too high.
Okay.
But maybe in your hands is better. We listen to that
Yeah.
in the afternoon.
So surprisingly, we were running on time today.
Henry, good point.
Yeah.
Can't leave a man.
We are. Yeah. Yes. I'm gonna give her mic.